Today. This is our 5th week of doing webinars, and our purpose of this and our intent is to take the downtime and just abundantly share. And because of that desire to share with doctors, we just wanted to bring with you some things today that are important to us and our patients. If you were in my institute today in Heber City, Utah, where I host most of my events and where I live, you would see on the wall a mission statement that says, Whitecap Institute, your total implant solution. Well, our mission for doctors who visit, or anybody who visit, is to inspire, motivate, and train like-minded dental professionals. When I say like-minded, I'm talking about doctors who love the game, who appreciate their patients, and thoroughly enjoy what they do every day. Now, to continue with this mission statement, to train like-minded professionals to confidently, safely, and predictably restore their patients with dental implant solutions. And I would have to say, if they truly need dental implant solutions, there's nothing better than a tooth. An implant is a good solution to a tooth that is hopeless, but never should we use implantology as a way of circumventing the use of natural teeth. And we feel strongly about that. And we're dedicated to promoting exceptional patient care. I have to tell you that over all the years of doing dentistry, now over 31 years, I started doing implants back in 1988. And so why do we do this? Why do we love dentistry? I've thought about it a lot. Why do we have the desire to get up every day, work our faces off for our patients? And for me, and I bet it's for you as well, the doctor-patient relationship is a very special relationship to me. It's the ability of transforming a human that is broken or somehow not functionalizing, and to have the privilege of helping them become better. To me, that is why I do what I do, and is why dental implantology and why dentistry in general is so satisfying. The doctor-patient relationship, if you really think about it, comes with great obligation. The obligations we have as a doctor with this relationship is to always do our best, always do the right thing at the right time for our patients. Now, it also comes with great further obligation. We have to use the best techniques. We have to use the best in class of everything that we do. And so over the years, there's been 4 significant game-changing things in my practice, and I bet it's the same for you. Number 1, dental implants were a game changer for me. I placed my first dental implants in 1988, and I have not stopped since. I thoroughly enjoy the opportunity to give back the function and the life to someone who has lost it. I find that the patient has great appreciation for that, and for some reason they're much more appreciative the second round after they've kind of destroyed what God gave them. The second game changer in my profession came with growth factors. When we do a venipuncture, when we draw the patient's blood and we have the capability of processing it and taking out growth factors and putting it back into the patient, this is a game changer. It's made my outcomes better. It's made my healing faster. It's made my patients more comfortable. And that I am very grateful for. That autogenous growth factor has been a wonderful thing. If you are not currently using growth factors in your practice, I would ask you why. What is your barrier to entry? Why aren't you using this great thing? It comes with your patient. All you need to do is harvest it and process it appropriately. So that was a big game changer, coupled with the existing dental implants that I do, made it even better. Now it even gets more exciting. The digital implant workflow. It first started maybe 15, 16 years ago with CBCT, where we could see things before we did surgery. We could measure things. We could know where we're going. It was very exciting. And then all of a sudden we have now intraoral acquisition tools of digital nature. We have software that we can merge STL files and the DICOM files together, and we can do planning. And I've never been more excited about dental implantology than I am today because of this digital implant workflow. I'm very proud to be affiliated and partnered with DO Implant Company, who I believe is a world leader in digital implant workflow. I personally have been pushing this digital workflow in my own arena in the United States for some time. And when I met the DO group of amazing people, it was a very easy choice for me to partner with them to take this digital workflow to a new level. If you're not familiar with it, look into it. You'll be very impressed, as I have been. And now the topic of our day and the last game changer in my core 4 game-changing things is photo functionalization. That's a word that, a couple of years ago I'd never even heard of photo functionalization. What in the world is it? But to me, we've been hearing about hydrophilic implants for a long time. I've used hydrophilic implants for a long time. I personally like the notion of an implant that's more wettable, but honestly, I have not seen a significant change in a standard implant and a proclaimed hydrophilic implant until recently. And about a year, less than a year ago, I was introduced to this little machine that can photo functionalize, whatever that means, we'll talk about it, a implant and transform it into a super hydrophilic. And for this, I'm excited to offer you some ideas. I am a clinician. My son Riley is a clinician. All we do is implant restorations and surgery. So I'm not in a laboratory. I'm not a PhD. I'm a clinician. I observe things through observational learning, and I can tell you that we're onto something very special here with this process.
You know, these are our personal game changers, things that have made a big impact in our professions and his profession. But what's really exciting is what these things can do for our patients. And so again, the patient is at the center. We have that special obligation in the doctor-patient relationship to always offer the most contemporary and best practices. And although this UV light activation, photo functionalization is a newer topic, it's an exciting topic, and we're excited to dive into it and talk about some of the benefits for us as a clinician and certainly for who it really matters, which is the patient themselves. Here's a quick little video that kind of shows some of the exciting things going on with the technology. So this here is your UV activator. The implant here is actually put into this UV activator and then run on a chair side application to prepare the implant for implantation, done just seconds before surgery. And this is just a little cartoon video kind of showing what that process looks like.
So you've prepared your osteotomy, everything's ready to go. You acknowledge with your dental assistant what implant you want. That implant is picked out. It's inserted into the machine. 20 seconds later, the process of photo functionalization takes place. And this is what magically makes it such a super hydrophilic, which allows the blood to optimize to the surface of the titanium.
So that's just our little video there. UV light is not a new concept in the medicine world. I just want to mention that for a little bit. This sounds sometimes a little Star Wars, a little out there, a little bizarre maybe at first, but we need to understand that UV has been used and is used in medicine today because it does have some properties that are unique. It does treat local infectious diseases. It can inactivate microorganisms, so different sterilization technique, and it's also been shown to stimulate the immune system. So the concept of taking UV radiation, applying it in a medicinal way is something that has been done in the past. It's not a foreign concept. What is new and exciting is that we're able to use it now in the dental implant world.
Now that UVC or UVB is referring to the UV type of light. There's an A, a B, and a C. Only are we able to use the B and the C. The A, I believe, is filtered through the ozone layer of the universe, I suppose.
So yeah, most of the research is around UVC, UVB, but it is, again, exciting to see how this radiation can be used in different medicinal ways. The question today is, how can we take a dental implant, apply this UV light to it, and what's the benefit of that for our patients and for us as clinicians? One thing I like to hit on a little bit is the unique implant design of DO. I think that's important to understand. You can't just take any implant and I think expect to get the same results that we're getting with DO. Their upper third, if you will, of the implant has a different micro surface as opposed to the body of the implant, which has a macro and a micro surface. Those different surfaces help with this process of UV light.
And I think it's important to understand that the cortical bone is a different bone completely. It doesn't have the vascularity that the trabecular bone does. The cortical bone gets its blood supply from the trabecular bone, from the inside, and the periosteum outside. It makes perfect sense to me that the nanostructure or the microsurfacing of the coronal aspect of your implant is a little bit different than the body of the implant, which is largely found in the trabecular bone where it's more blood supply. So we do really like the thoughtfulness of the enhanced surface area of the implant body. It's more of a parallel walled with a tapered to optimize primary stability. That coupled or added to the UV technology is what is very synergistically exciting for us. And we've both been using this product and things for about 5 or 6 months, place implants every day, UV activating them, and we're seeing some phenomenal outcomes, and excited to share it with you.
So here's just a more practical video, not so much a cartoon, showing again the DO UV activator. Again, this is a chair-side application, so this device is actually in the operatory or right down the hall from the operatory. There's a little window on the top that opens. The special capsule, which is important that you do not touch the outer area because it is important that light penetrate through it without any oils or grease. It goes in, the door is shut, the implant then goes down into a special design structure to help optimize that UV light. And it takes about 20 seconds. So again, practically speaking, you're drilling the osteotomy, you finalized your implant size, you ask the assistant to UV activate it, and that's done there chair side right in the operatory. So this is done just before, and that's one really unique feature, is that this is done just seconds before the implant goes in. Some companies might follow some type of process to make the implant more hydrophilic, but then it might sit on the shelf for months or years, and those effects will decrease over time.
Now, I have to admit to you, I am a little bit of a skeptic. When I first saw this machine and I saw the blue light going on, which has nothing to do with the photofunctionalization, by the way, it's all done in the belly of this machine, I thought, is this possible that this is hocus pocus? Could I replicate this? So you're going to think I'm crazy, but I took a bunch of my light curing devices and I thought, I can photo-functionalize an implant. I'm just going to hold it and use. I told my dental assistants, I said, get me 4 or 5 of these things. So I got all these UV lights and I'm photo-functionalizing my implant, thinking it had something to do with something super easy. Of course, it did nothing. I thought maybe it was the heat that was doing something, that maybe the heat or warming an implant up a little bit by that light had something to do with it. Had nothing to do with it. I spent a weekend of experimenting, trying to replicate this. I'm kind of embarrassed to tell you, but I did it. And I can tell you that right now, there's something very special. And what I learned is there's a very proprietary capsule that the implant goes into. And that capsule is oxygen-free. And that capsule acts like a prism, if you will, to optimize or potentiate the UV B and C rays that are exposed to that implant that allow it to be photofunctionalized, which allow it to be super hydrophilic.
So, here's a standard test. You might have seen this in some different PowerPoints from last week that Dio had. But in the middle, you're seeing a Dio implant right after it's been UV activated, and on the sides, the left and the right, are different manufacturers that claim that this is their hydrophilic implant. And this is a great little water test. They're going to dip these down in a liquid medium, and we're going to see the effects of UV activation. And again, that's company A and B, both their hydrophilic implant solution. Very, very different. You're seeing the surface tension still actually create a distance between the titanium and the implant. And so that is a really, really unique. When we talk about hydrophilicity, this is next level. This is super hydrophilic, seen here in the video.
When I put my dental implant into the insertion tool and I go into the osteotomy of my patient and there's blood in the osteotomy, I actually see this blood transmit itself up the long axis of this implant. It's compelling because blood is the magic for osseointegration. Did you all hear that? Please be clear. Blood is the magic for osseointegration. The way manufacturers have made implants so intimately fit to bone, trying to optimize bone to implant contact, I think is silly. I think it gives us primary stability, but at the end of the day, be clear, it is the blood of the body that allows the integration, and the blood to implant contact of an implant, the more wettable the implant, the more wet it is, the more blood that we get exposed to the implant, the more bone implant contact we get. And that's the gist of why we're so excited about this, is we're seeing some healing that is phenomenal in a very short order, and it is all about the blood. And for years, I used to, at the recommendation of a dear friend of mine who's an oral surgeon in Portland, Oregon, he would take his implant prior to putting it in the body and he would saturate it in saline. Saline being an isotonic sterile solution. After sitting it in that for 3 or 4 minutes, he would see a notable change on the implant color. It was more wet. It went to a darker gray, to a light gray, to a darker gray. And his thought process was the more wet it was, the more the blood could get into the nooks and crannies of the nanotechnology or nano surface of the implant. This is exactly what's going on here, not just by wetting it ahead of time, but by changing the chemistry of the surface of that implant with a UV activating machine that is remarkable in 20 seconds, doing what competitors have worked for years trying to do in 30 or 40 hours ahead of time with that light exposed for 40 hours, which, I don't even know what I'm doing in 40 hours from now.
So the effects that this light has on the titanium are basically twofold when you really go through the research. And I went through a lot of it. They all kind of say the same thing. These are the two big messages. It reduces the surface hydrocarbons and increases the surface energy and wettability. Wettability is kind of like the $5 word for just hydrophilicity, and we'll talk about that in just a little bit. The second thing that it does is it raises the level of protein absorption and cellular attachment to the titanium surface. So that's really the what's going on, the science behind it. Again, there was a great lecture last week that talked about that. I don't want to dive into that too much, but these two facts right here is what the research is showing. And it's especially important in that first 1 to 4 or 5 weeks of healing time. That's when we're really seeing the biggest difference. Now, more research is being done for long-term studies, but all of the short-term studies are showing these two common facts right here.
One of the things that I learned as I did some brief research on who is the leader in photofunctionalization in the world. And one of the world leaders, and I'm proud to have met him. I went down to UCLA. Dr. Ogawa is a world leader in this, and we brought him this special machine, and I wanted him to kind of give us an assessment of it, and his outcomes will be there will be papers on the amazing things that he's finding out about this, but he knows that we have something very special, and made me feel good that a world leader substantiates what I am using for my patients, and that there's nothing better out there by a long shot, nothing close.
So this concept of wettability, they actually measure it by looking at what they call the water contact angle. And if that angle A there on the left, B on the right here, if that is less than 90 degrees, they're calling that a hydrophilic surface, where you're getting more surface area of the blood on the surface. If it's more hydrophobic, you're going to see it kind of curl up and not want to touch the surface as much, creating more of a large angle greater than 90 degrees. And so if you could imagine, this is obviously at a macro level, and we're going to show you some videos at a macro level of big water droplets and things like that. But if you could imagine more at a molecular and a cellular level of all of these different proteins, these different molecules that are inside of our blood sitting more intimately on a titanium surface, you could imagine what that increased surface area is going to do for healing, protein binding, and just the intimate nature of the molecules that really facilitate osseointegration. This is a really big concept. Increasing wettability is essentially taking that curve, making the angle even more acute, creating more surface connection with the titanium.
It's a fine balance because you've got micro etching and macro etching of your surface by acid and sandblasted mediums. That's to enhance the surface area. All together, they have to come together and be a magical combination of just the right everything. This hydrophilicity or super hydrophilic surface of these implants, to me, is just a clinician, a game changer for me, because I'm using them in patients that I need extra help. An autoimmune patient, an older patient, an implant that's already had failure, or something that just needs to be done rather quickly. So it's intriguing how this hydrophilicity is changing the outcome for me as a clinician.
So here you're seeing just a simple picture of a titanium puck or block, and this was exposed to different water. In the left, this was before any UV activation was done, and on the right, believe it or not, there's a thin layer of water just barely over the top. You can see the difference there. And if you just imagine that again at a molecular level, zooming down into all of that nano structure of a surface of an implant, and imagine a tighter fit or tighter connection of the water, or the blood in this case, of the implant surface, you could imagine the benefit there. So again, taking the titanium, by photofunctionalizing it, creating more wettability and allowing the blood to more intimately bond to the titanium, which has all of the growth factors that are going to actually facilitate osseointegration. Here's one of my favorite little videos here that really highlights this. The video on the bottom is actually playing all the way through. So it's going to look like a still image here, but it is actually still moving there. But that's a little droplet of water sitting on the implant before activation. Now here's what it looks like after activation. And that's just fascinating there when you talk about surface area, you talk about biochemistry and getting the blood to really intimately contact all of the surface area of the implant. Clearly, the UV active does a lot better. That's a really fascinating reality there of the wettability and what the UV light can do.
But you've also got to take this picture and compare it to, put your mind into this game. You're screwing this into bone where some of the bone to implant contact is so intimate, it's not even letting anything in there. And it might be in an area of bone that doesn't have a lot of vascularity, like cortical bone. So you take this wettability of the lower compared to the upper, and then add it together to an insertion to a human body, that's a big deal. And let's say you overdid it with your epinephrine, and you vasoconstricted that vascular site, and you don't even have a drippy patient. All of a sudden, these things add up to why things heal and why things don't heal on a routine basis.
So again, talking a little bit about just the science here and what's going on, there's this concept of aging titanium, and the organic matter that forms on the implant surface after it's been processed due to air exposure, that can actually disrupt the osseointegration.
So Riley, I think there's an aging process that happens to implantologists. I'm experiencing that right now.
He's been exposed to air a little
There's been
too
a
long.
lot of organic matter that's formed on me. But interesting, air has hydrocarbons in it, and titanium wants a propensity to create a titanium oxide, and that's where your organic compounds get attached to that implant. I never really thought about it. I thought an implant in a box sterile was an implant in a box sterile. But as they get older, apparently, like implantologists, we're not quite as active, bioactive.
Well, and that's going to disturb our osseointegration. The surface was designed a certain way right out of the factory to be optimized, but with time, it is not as optimal as it could be. Now, does it work with this aging effect? Yeah, they work, but the thought is, can we mitigate or reverse those effects, therefore enhancing and optimizing that integration process? So with UV light, it will go and it basically removes that organic matter. And by removing the organic matter, the oxide layer is more exposed, which makes it more wettable, which then is a more fast and more stable osseointegration.
But all of this, don't think for a second that we're letting it age and now we're making it young again before we put it back in the body to optimize its bioactivity. All of this is done by science as it's manufactured. So as it's manufactured, we've lessened the titanium to any oxygen prior to it even going into its airproof capsule. So I think this concept is fascinating. It never dawned on me that an implant could be aged and not bioactive as much as, say, a brand new implant. Crazy, but you learn things every day.
So this is a really important here, and before I read this statement here, I think it's important that we just remind ourselves of all of the biological implications associated with implant dentistry. Implants are so mechanical in nature, and sometimes we get so caught up in torque values and tightening and things fitting lock and key style and different prosthetic components, where it is very kind of like building a home. There's a lot of mechanical things going on, but we have to be respectful of the biology. And when we dive into the biology, this concept of activation and of more cellular propensity to work on the implant surface, that it's exactly what the body's asking for, because it's a biologic response.
But we have to give credit where credit is due. This paragraph, brilliantly written, I think, because he's my son. You're always proud of your sons. This was done by Riley. He just came up with this. I think it was quite profound. You didn't put your name on it, Riley.
That's okay.
But basically, tell us what you meant here.
Well, I'm just going to read it to you. When placing implants, we force a biological response of wound healing. Wound healing requires multiple cellular functions resulting in bone formation on the titanium surface. If these cellular functions more readily accept their titanium host, the end result is faster healing and superior implant bone to implant contact. And so again, getting down to the biology, I think is really, really important. There seems to be kind of a trend in the industry of tighter implants, primary initial stability. That is not biologic. That is not the magic that Brandemark helped us understand. It is the concept of bone growing and healing to the implant. That is the magic, and this is simply optimizing the biology. And so it's biology focused, that's the foundation, and we're being very clever with different biological approaches, scientific technology approaches to enhance the biological response.
And it's many years I've been teaching this principles of blood is the magic that creates osseointegration. When you take an implant that has a hole in it years ago through the apical end of it, and you take that out years later, there is absolute bone in there. That happened because blood got there. If I had to put an implant in too tight, meaning over 40 Newton centimeters, or too loose, meaning it was a spinner, which could only be healed through a two-stage healing, and I could only live in one camp for the rest of my life, too tight or too loose. Believe it or not, because of this blood, I would take too loose over too tight. Because too loose, yes, I couldn't primarily load it. Yes, I couldn't do a one stage. Yes, I agree with all of that. However, the blood is the magic that makes the integration happen. And what you've phrased here, Riley, I think is really so nice. When we create something within that titanium host that speeds it up, wets it more than others, we're going to get more bone to implant contact. You researchers out there are going to prove that, but it'll take you a little time to get that research and published. Us clinicians have to kind of go for it here, but we see it daily in our practices. So this bone implant contact, BIC, it's the big buzzword. We're going to suggest there's a new BIC on the block. The new BIC on the block is blood to implant contact based upon hydrophilicity of the initial insertion of the implant equals bone implant contact, which has been around for a long time. It's been studied. It is our strong clinical observation that the more wettable the implant, the more suitable it is to have every nook and cranny covered in blood, will create a optimal or a better bone to implant contact versus a non-hydrophilic structure, coupled with all of the other nano, micro and macro etching and all of that combined. But that is our premise as non-researchers.
So just a short little clip here, video here, looking at the structure of bone. And
this is what we see every day if we had a microscope, right?
Yeah.
An electron microscope. We're just looking at some trabecular bone, very nice bone, little D3-ish, little D2.
Little vessel
good vascularity. Yeah. Propensity for a little osteoporosis. Oh, it's shaking around a little. Oh, here comes the burr.
So this again just really helps us understand really what's happening here. And I love this video. It's a simple little video, but it gives the respect that is due of what's really happening biologically. If this video did not have blood vessels in it, then it would be like drilling in bone. But we're not drilling in bone or drilling in wood. We're drilling in bone here. And so this concept of when we're drilling, we're breaking vessels. And as we're breaking vessels, contents are being spilled out. And those contents are the complete magic, the complete why. It is the underscore of why this actually works, this concept of osseointegration. And so I just want to, again, keep us focused on the biology and help understand this concept of UV activation of the implant surface. It's not Star Wars. It's not this weird concept. All it is doing is taking biological principles and applying them in a way that produces a better result. So this concept of wound healing, I think, is really important. First, we know after blood vessels are broken, we have a wound to heal, and there's 4 steps in that. We have hemostasis, inflammatory phases, proliferation phases, and then remodeling phases when we talk about bony healing. And within minutes of drilling into that bone, hitting blood vessels, ions and proteins are going to be released. They're going to begin to adhere to that titanium surface as it goes in. If those proteins and those ions, which are in blood, if they are able to adhere more tightly, more wettable-like to that titanium surface, it's going to benefit us. Where we really see the big benefit here is in the proliferation phase. In the proliferation phase, we have fibroblasts that show up, osteoblastic activity increases. If that activity and if those cells can adhere more tightly, more flat, if you will, on the implant surface, then we're going to obviously have a better integration on that titanium surface.
I want to go back to number 1 for a minute. You know, you've got to think biology, not mechanics. But as mechanics, we think just prepare the osteotomy and put it in, reasonably tight, and that gives you the ability to primarily load it. But don't forget the blood. The blood has the host's immune system within it, and if that blood isn't homogenously placed over the surface of that implant, that is where infection can go. Because when there is no blood, there is no mitigation of infection. And we're operating in a field where there is bacteria, be clear. And we need that blood to bathe that implant and protect it in those first few minutes, or they will leave your operatory with a brewing infection that will necessitate a removal of that implant before the end of the week. It's just an interesting thought. But this proliferation phase, Riley, I have to agree, is where we're really seeing clinically the difference with our ISQs. At 1 week, 2 weeks, 3 weeks, 4, we're seeing things we've never seen before with the hydrophilic, super hydrophilic implant that's been photofunctionalized by this process than the traditional hydrophilics that just came out of a bottle.
So again, to that point, here you're seeing some different charts. On the left, you're seeing kind of the concept of a traditional implantology where old bone is going to go away with time, new bone will begin to remodel, but really doesn't really substantially remodel till 4, 5, 6, 7 weeks into the process. With UV activation, we're finding that we get stable osseointegration 2, 3, 4 weeks after implant placement. Why? Because again, the cells and the proteins found within the blood are able to integrate and work more intimate with that titanium surface because of it being activated. And so really, really fascinating. What does this really practically mean? It means implants are healing faster, stronger, and because of that, we can get patients to their in solutions quicker and with a better product at the end of the game. Not just quickness, but with stronger, better, more bone density around the implant.
And you know, the two doctors that I'm familiar with in Busan, Korea, both Dr. Chong and Dr. Lee, were doing UV activated implants before you and I were doing them. And I asked them, when do you feel, based on ISQ, you can restore these based on your standard implants? And they said at 4 or 5 weeks. I said, excuse me, did you say 4 or 5 weeks? And did you mean upper or lower? And they said, yes. And I thought, So the other day, I had an implant, a young girl, congenitally missing number 7 and 10, and she really wanted her teeth for Christmas. We were making a joke. All I want for Christmas are my front 2 laterals. Anyway, she comes in to get that process done, and number 10, when I uncovered it, had an ISQ of 50 and a 55. Number 7 was above 70, and so obviously I had a disappointing outcome with number 10. I took it out, I debrided the area. I'm just feeling bad for her because we promised her teeth, and you know how that goes. It breaks your heart as they're disappointed in you and with your outcome. So I went ahead and photofunctionalized a new implant. I put it in. She came back about a month later, and I thought, oh, whatever, let me just uncover this and ISQ it and probably nurse it along for a number of weeks. I uncovered it and I had ISQs above 70, and I went ahead and went forward with the case. And that was a very nice example of how this can have clinical relevancy in my practice. I would not have expected at 4 weeks with a failed implant to boot, and this is very meager bone. It just had all sorts of challenges, but it worked very well.
So again, by creating more of a hydrophilic surface, there's more surface area for the chemical activities, proteins to attach, and by doing that, we're going to see more cellular activity on the implant surface itself. And by having that, we're going to have not just more bone-to-implant contact after healing, but faster bone-to-implant contact because of the increased surface area that the chemistry can work on.
Now, one could imagine these jagged areas in the upper that you see where the hydrophilicity isn't what it should be. You kind of drag across those, so there's a vacancy. I would suggest that that's not only where the threads are, that could be where the nanotechnology or the nano etching has these cul-de-sacs of isolated titanium that would benefit hugely from having the blood in those little cul-de-sacs to create a tighter, more abundant bone-to-implant contact.
Again, blood is the magic. And so here you see implant on the left, dipped in blood, implant on the right, dipped in blood. The one on the right does have UV activation on board. And you're seeing the different intimate, just mass volume of blood compared to the alternative. And we really just want to emphasize of the biologic process of osseointegration and the benefits, biologically speaking, that UV activation can bring to the implant. That's really the magic. That's where the tire meets the road. Nothing exemplifies it better than this great little picture right here. Let me show you, let's talk about some practical clinical applications. And these might sound kind of obvious, but if there's soft, weak, or insufficient bone, this might be a great opportunity to do that. If you're bone grafting simultaneous, great option. Immediate placement. If it's simply faster treatment time the patient's looking for. You know, patients I think struggle with two parts of the implant game. First, the cost. Implants are not the most economical treatment modality. Second, the time that it takes. And so if we can solve one of those, or at least remedy the duration of healing required, I think patients are going to be really happy. Complex surgeries, elderly patients that maybe have immune systems that do not heal as well, replant due to past failures. We just had a story about that. I'll share another one in a couple of minutes. And then just a poor immune response due to their health history. And so we have a biological opportunity to enhance that gap where the old bone is going away, new bone is coming, and creating more of a constant strength for the implant. That's a really, really powerful situation. Here's just a little snapshot from some of the research out there of 4 different implants that were placed. You see pre-op, 3 of the 4 are below 70. And by week 2, all of them are above 70, some even in the 80s. And so these ISQ levels, week 1, 2, 3, 4, really, really impressive that at week 2 and 3 to see that much growth, really, really impressive.
And we have seen similar numbers with our own hands, with our own ISQ instrumentation in our own practices. Not that we're researchers, but we're just trying to figure out, you know, as much information as we can to gain our confidence in this. And we're seeing similar things in our own clinic.
Lastly, here's just a few photos of one of the first cases I did with UV activation. And so this patient, top left, you're seeing the picture of 3 healing abutments. I had 1 implant fail. You can kind of see that in the upper right posterior where the tissue looks a little bit different there. This patient was devastated. She'd been healing for about 3-4 months. She's been in a floppy denture during this interim healing time. We come in to uncover the implants and we had 1 failure, unfortunately. I told her, this is just when I started working with Dio, I told her there's a new technology out there that may allow me to put in an implant and in about a month actually be ready to restore it. She loved that idea because the alternative was put in an implant, wait another 3-4 months like she had previously for these 3 implants. She was so excited. So we got the UV activator, got some implants, came in, reflected a little flap, found some tissue where we thought or some hard tissue where we wanted to drill, went ahead and activated the implant, put it in, closed it up, and I said, I will see you exactly 4 weeks from today. She came in, I uncovered it, ISQ'd it, and I had 75 all the way around the implant, went ahead and restored it, put on locators, had dentures made in the next week. And she was so happy and she was so grateful. So getting back to our concept of the doctor-patient relationship, the concept of giving them the very best that we can, this is a really unique opportunity that we have, and it's a new opportunity. The concept here is still being researched with long-term studies, but what we're seeing initially is really, really exciting. Patients are excited about it. It's really a win-win for everyone involved. It's just an awesome opportunity to be able to offer this to our patients.
And you know, when we first started, we talked about that doctor-patient relationship. It comes with an obligation to do your best and use the best. This is our experience. We're excited about it, and we'll keep you posted on the future. And we appreciate your time today. We hope you're all well, and we hope to all be getting back into dentistry once this pandemic clears. And I think we're going to be a much more grateful world when this is done.
Thank you so much.
Thank you.